All right. Thank you very much, ladies and gentlemen. Thank you for the program committee for inviting me to present today. I'd like you to stay awake. There's jet lag. It's a late afternoon talk. Please stay awake and with me, and I will show you 5 points, and I'm going to be brief. I'm going to skip some slides because I have to be grateful for Professor Adam and for Professor Christophe of presenting already some of my slides. So, you have to open your eyes when you look at colorectal liver metastasis first. Open your eyes in pathology and in radiology. It's going to be point number one. Then, is it useful? Do we use RAS in our selection for resection? How do we use it at our institution? Then I'll talk about the resection margin, which was alluded to, then ablation and RAS mutation, and then there will be RAS fatigue in this group, RAS fatigue, and I want you to wake up because I present you with new data regarding TP53 and SMAD4, and I will allude to BRAF. So you open your eyes and you don't only look at the chart here and at these things, lymph node, CEA, and those predictors in 2018, and you can get an idea what's going on because patients receive chemotherapy. Now, 85%, in fact, 95% now at our institution preoperatively is the way it's going, and it's irreversible. So one thing you can do already, you can infer about the biology by looking at the radiologic response, and you're all familiar with that, and you know that it's better than the RECIST, than the shrinkage. If you have this cystic appearance on the CT, cystic appearance, well-defined margin, you know you have a fibrous or almost fibrous desert, and the survival is better, and it's good for patients who are unresectable. See, because you're also part of this game. You ask the pathologist to look at it. You can look at it with the pathologist. It's easy. Percentage of viable cell. So that's 5 days after surgery at our institution. And we discuss with the patients the finding of the pathology. They want to know, and you look intelligence. You give them the percentage of viable tumor cell. Now, this morphologic radiologic response and this pathologic response, what's behind it? It's RAS. Fourfold increase in suboptimal morphologic response with RAS mutant, and almost threefold increase when you have minor pathologic response. You've seen this paper. We've shown that RAS worsened disease-free survival and overall survival in meta-analysis. The good news for you is that you can use the primary. There's concordance between the primary and the metastasis. There was some trepidation when I started presenting these data, but in fact it goes beyond RAS, TP53 also, very stable, and this is the concordance here. I don't want to go into detail. Selection for resection. So the disease that's most advanced disease that's treated with surgery is treated with two-stage hepatectomy, and that's where you see the most profound effect of the RAS mutation. Looking at 93 patients here with RAS status, we found that in fact we had only one survivor in RAS mutant, and we had 16 survivors with RAS mutant at 5 years. We are using RAS also in the patients mentioned by Professor Adam, patients in whom we resect the liver metastasis in the presence of unresectable lung metastasis. Lung metastasis don't kill patients. Patients don't die from lung metastasis, or they are very late in the course, so they don't die from respiratory insufficiency, and they can be treated also with off and on chemotherapy, low-dose chemotherapy, de-escalation. So this is an example of a lady who survived. She had young children, and she survived after 44 months of liver resection, died from her disease. You have a score here. You have an intermediate situation with liver resection only here in the presence of unresectable lung mets, but what you can do before you do the surgery, you can look at the RAS status and select these patients based on the RAS status. If you have the RAS status, you are here. And of course, this is not a surgical curve with a plateau. It's a curve with a shoulder now, but you're better off if you select your patients for this type of approach, unresectable lung mets with resectable liver mets, if you are in the presence of RAS wild type. Resection margin, these two slides were presented by Dr. Christophe, so I won't go over it. The margins still matter in the era of new chemotherapy, but the margins are in the RAS status is influencing the margin here. Wild type 5.4% positive margin versus 11.4% RAS mutation. And here you see that the margin on average was also for the same size tumor, almost same size tumor here, that the margin was narrower when it was measured. We measured the margin systematically, prospectively, was narrower. So the tumor is really different also morphologically and pathologically if it's RAS mutated. What's the implication here? Well, there's an implication. We intend our margins when we score the capsule of the liver with ultrasound to define our margin of resection. So if we can, we're aiming at 15 millimeter in RAS mutant or in patients in whom we don't know the RAS status to avoid a positive margin. Now for ablation, also we have data, and we used to use 5 millimeter margin for ablation. Now we use 10, and why? Because of our data from our interventional radiologist. Up until 2017, we were using 5 millimeter and margin, and even in small tumor, we had a very high local recurrence in patients with RAS mutant, and even higher, 50% in patients to RAS mutant. So this has a practical implication, and you see here in red, patients with wild type RAS and local progression, they tend to have larger metastasis. But you see here all these blue, very early recurrence. You see 100 days is here. All these blue after ablation, 5 millimeter margin in RAS mutation. So you have to discuss that now with your interventional radiologist. And in fact, these data have now been confirmed by the Memorial Sloan Kettering. So that's not a Vauthey-ism. Multiple mutation. Now you need to wake up, because this is a good news here, sort of good news for the RAS mutant or a small subset of RAS mutant. We do now 140 mutation panel, but up until recently it was 50. So we have a lot of data on this. And these are the ones you need to pay attention to now. BRAF is mutually exclusive with KRAS. So when KRAS mutation, BRAF is wild type, and vice versa. So I'm not going to talk about the BRAF, but I'm going to talk about the double mutation, KRAS in addition to SMAD4, KRAS in addition to TP53. Why? Because BRAF is 1% of your liver resections, 1%, bad prognosis if it's V600, and that's going to be the end of my discussion. SMAD4, about 15% are mutated, and up to 70% TP53 are mutated. Elephants don't get cancers. They have more than 50 copies of TP53. I had the privilege to have this panel in front of me in my clinic, and I saw some patients with RAS mutations who were recurring extremely quickly after liver resection. So with the assistance of Dr. Passot from Lyon, we looked at patients who had RAS mutation and TP53 mutation. So you have 4 groups here, very simple, double mutation, a mix here, and you have the wild type here. So we looked at RAS mutated patients who have this oncogene mutation according to TP53 mutation. And you see that not all patients with RAS mutation, the TP53 is intact. You're not going to have the dip in survival that you see typically associated with KRAS. Now there's SMAD4 here. SMAD4 independently predicts survival after resection of colorectal liver metastasis, 37 patients out of 280 almost. And this shows also, this effect is shown in patients with unresectable disease. So now we have a KRAS that's not sufficient to predict prognosis because you have in the background of these 211 patients who have other mutation and other patients who don't have other mutations. And the breakdown is shown here. So I was asked earlier, do you exclude patients? How do you use RAS in your two-stage hepatectomy? Well, we have this information now, which is, I believe, important because we have good news for 62 patients, about a third of the patient with RAS mutation. So essentially here, if you compare RAS wild type versus RAS mutant with wild type TP53 and SMAD4, the difference in survival is not there. But if you have one of the two mutations, TP53 SMAD4, or double mutation, you are here, and you find the same difference when you look at the different subsets of patients with in recurrence-free survival with multiple mutation. So I've just presented you now with problems in 3 different pathways of the colorectal carcinogenesis. This is the MAT kinase pathway here with the RAS mutation, oncogene. This is the accelerator. Here, the TP53, the tumor suppressor gene, TP53 pathway. When the brake is off, obviously, that's going to be bad news for the patient. But if you have another suppressor gene here, SMAD4, if a second brake is off, your handbrake and your pedal brakes are off, you are in very bad shape. So how do we integrate this in our practice today? Well, we're not even arguing anymore about the resectable here because I gave you this alternate pathway where you can do whatever you want. If you don't want to give chemotherapy, that's fine. I will not be offended. But unresectable patients, pay attention, or patients borderline resectable, pay attention. You look at it, even if the patient's never going to be resectable, because grandma and grandpa, you want to know if they have a good morphologic response. You can send them, the medical oncologist say, I can't resect, but still you have 2 or 3 years of survival if you have the cystic appearance. So that's the immediate response. Anticipated margin, I think you should change your margin habits if you can. And then the mutations, they are here. If you have them, use them, because they'll be helpful in these patients, borderline resectable. Thank you for your attention.